Apotemnophilia, also known as body integrity identity disorder, BIID, is a rare and complex psychological condition characterized by a strong desire to amputate a healthy limb or to become disabled. This condition raises profound questions about identity, body image, and the nature of desire. The term, apotemnophilia, was coined by psychologist John Money in the late 1970s. In his seminal work, Money described individuals who experience sexual arousal from the idea of being an amputee. He noted that this desire often stems from a profound mismatch between an individual's physical body and their perceived identity. While the sexual component of apotemnophilia is debated, the core of the condition revolves around the intense longing for amputation or disability. Individuals with apotemnophilia may exhibit a range of symptoms, including desire for amputation, a persistent and overwhelming desire to amputate a healthy limb. This desire can lead to significant emotional distress and social dysfunction. Distress and isolation. Many individuals feel isolated due to their condition, as they are aware that their desires are socially stigmatized. This can lead to feelings of shame and exacerbate mental health issues. Pretentious acts. Some individuals may engage in behaviors that mimic disability or seek to present themselves as disabled, further complicating their social interactions. Self-harm. In extreme cases, individuals may attempt self-amputation using dangerous methods, leading to severe injury or death. Reports indicate that some individuals have resorted to using tools like saws or knives to achieve their goal. The exact causes of apotemnophilia remain unclear, but several theories have been proposed, such as neurological factors. Some researchers suggest that apotemnophilia may be linked to neurological conditions that affect body image perception. For instance, individuals with certain brain injuries may develop a disconnect between their physical body and their sense of self. Psychological factors. Trauma, particularly during childhood, may contribute to the development of apotemnophilia. Individuals may cope with trauma by dissociating from their physical body, leading to a desire for amputation. Identity issues. Many individuals report feeling that their body does not align with their true identity. This sense of incongruence can lead to the desire for amputation as a means of achieving a more authentic self. Several notable cases have been documented, illustrating the complexities of apotemnophilia. Case study of Mr. A. In a well-known case, a man known as Mr. A. expressed a strong desire to have his leg amputated. He reported feeling that the limb did not belong to him and that removing it would bring him closer to his true self. After extensive psychological evaluation, he underwent a surgical procedure to amputate the leg, which reportedly alleviated his distress. John, another individual, referred to as John, sought amputation of his arm. He described feelings of euphoria at the thought of being an amputee and engaged in self-harm attempts to achieve this goal. After receiving therapy, he was able to manage his urges but continued to express a desire for amputation. Treatment for apotemnophilia is challenging due to the rarity of the condition and the lack of formal diagnostic criteria. However, several approaches have been explored. Psychotherapy. Cognitive behavioral therapy, CBT, may help individuals manage their urges and address underlying psychological issues. However, it does not appear to reduce the desire for amputation. Medication. Some studies suggest that antidepressants, such as fluoxetine, Prozac, may alleviate some distress associated with apotemnophilia. Benzodiazepines like oxazepam have also been explored for their potential benefits. Surgical intervention. In extreme cases, individuals who have undergone elective amputation report a reduction in emotional distress post-surgery. This controversial approach raises ethical questions about the appropriateness of performing surgery on healthy individuals. The ethical implications of treating apotemnophilia are significant. Some argue that allowing individuals to undergo surgery may mitigate the risk of self-harm, while others caution against normalizing such desires. Vorophilia in humans. Vorophilia, commonly called vor, is a paraphilia centered on the eroticism of consumption, being eaten, eating others, or watching the act of devourment. While often associated with mythical creatures or animals, human-based vorophilia is a prominent subcategory, where fantasies involve people consuming or being consumed by other humans. We are going to explore the psychology, variations, real-world expressions, and ethical considerations of human vor, with explicit examples to illustrate its diverse manifestations. The appeal of human vor stems from complex psychological and emotional triggers. The predator embodies absolute control, while the prey experiences total surrender, as the idea of being inside someone forever or absorbing them completely can symbolize extreme closeness. The terror of being consumed merges with sexual excitement, similar to horror erotica. A victim struggles in the grip of a cannibalistic lover, moaning as teeth sink into their thigh, pain mixing with perverse pleasure. Some fantasize about being digested and reborn, or transformed into fat muscle, as the prey's last conscious thought is their body melting into their predator's stomach acids, their essence becoming part of their lover's flesh. Basically, these individuals gain arousal by describing how they'll break down their prey's body in vivid detail. Ahead are some examples of how people with vorophilia mix eating each other with sexual interactions. Oral vor, OV, swallowing whole. The prey is gulped down alive, often with detailed focus on throat bulges and stomach movements. Illustration. A woman kneels before her partner, opening her jaw wide as she engulfs his penis. She then chops the male's penis off with her teeth and swallows it whole. Hard vor, chewing and dismemberment. Violent consumption involving biting, tearing, and fatal digestion. Illustration. A man or woman bites into his partner's flesh, usually places like breasts and hips and thighs, as these parts are mostly muscle and more eatable, while blood dripping down chin as chewing noisily. Sometimes it gets even crazier as the consumer rips off a whole arm or leg next, eating the warm meat as both parties gain extreme arousal, and on rare occasions they even reach climaxes. For some, vor is escapism. For others, it may stem from anxiety about intimacy or control. This condition is a complex, multifaceted fetish that blends fear, power, and intimacy into a uniquely extreme fantasy. While unsettling to outsiders, it provides deep psychological satisfaction for those who engage with it. Fregoli delusion. Fregoli delusion, a rare and fascinating psychological condition, is classified within the spectrum of delusional disorders. Named after the Italian actor Leopoldo Fregoli, known for his remarkable ability to impersonate others and change his appearance, this delusion involves the belief that one or more people are able to constantly change their identity and disguise themselves as different individuals. Those who suffer from Fregoli delusion often feel as though the individuals they encounter are not who they claim to be, but are instead close acquaintances hiding behind various facades. Fregoli delusion first entered the medical lexicon in the early 20th century, following the case of a patient who believed that various people she encountered were actually a certain individual, her malevolent friend who had the ability to change appearance. This condition, initially characterized as a direct consequence of paranoid beliefs, evolved into a named phenomenon in psychiatric studies. Named after the noted performer Fregoli, the condition highlights the intriguing intersection between delusion and the human experience of perception and identity. The Diagnostic and Statistical Manual of Mental Disorders, DSM-5, classifies delusions as fixed beliefs that are resistant to reason or confrontation with actual facts. In the case of Fregoli delusion, specific features include identity misattribution. The affected individual believes that certain people in their environment are actually someone they know, often interpreted as a malicious intent. Paranoia. Patients frequently exhibit paranoia towards the individuals they believe to be disguising themselves, fearing that these imposters are out to harm them. Cognitive disconnection. There's a disconnect between the patient's recognition of physical aspects of a person and their belief about that person's identity. Fregoli delusion can often be misdiagnosed as other conditions, including schizophrenia, paranoid personality disorder, or even dementia. A thorough assessment that considers the patient's history and the consistency of their beliefs is crucial for accurate diagnosis. The origins of Fregoli delusion are often attributed to neurological causes. Several studies have linked it to abnormally functioning brain regions involved in processing identity and recognition. Neuroimaging studies have revealed varying brain activity patterns in those diagnosed with Fregoli delusion, suggesting that both structural and functional abnormalities may play a role in the onset of this disorder. Here are some cases who suffered from this delusion. The disguising neighbor. A 34-year-old woman, referred to as Sarah, experienced the Fregoli delusion following a traumatic incident involving an ex-partner. Sarah became convinced that most of her neighbors were in fact her ex-partner in disguise, attempting to manipulate her. Convinced of this identity transfer, she began to avoid leaving her house. Whenever she encountered someone she felt was being deceptive, she would confront them, creating situations that strained relationships and led to her isolation. With therapy, Sarah was able to gradually re-establish her social connections, learning to recognize that her fears stemmed from her traumatic experience rather than genuine danger. Mr. Albright. In a renowned psychiatric hospital, 52-year-old Mr. Albright believed that every staff member was actually his long-lost brother, who he believed was stalking him. This delusion led him to engage in erratic behavior, including attempting to escape the hospital to confront his brother. His treatment plan involved antipsychotic medication and intensive therapy that worked through accurate reconstructions of reality. Over time, Mr. Albright developed insights into his delusions and was eventually able to differentiate between his brother's presence and the identities of others around him. The relentless stranger. Another compelling case involves a 40-year-old man, John, who was convinced that a particular barista at his local coffee shop was consistently changing identities. John started to believe that this barista was not only various people he recognized from his past but also starting to pretend to be his ex-wife. Not only did John confront the barista multiple times, but he also spiraled into a deep-seated paranoia that prevented him from entering the coffee shop altogether. Eventually, through therapy, his fixation was addressed, and he realized that his belief that the barista was impersonating his ex-wife stemmed from unresolved feelings related to their breakup. Treating Fregoli delusion typically involves a combination of psychotherapy and pharmacotherapy aimed at alleviating symptoms and improving the patient's quality of life. Antipsychotic medications, such as risperidone and aripiprazole, are often used to help manage delusions. However, given the rarity of the condition, research on the efficacy of specific treatments for Fregoli delusion is somewhat limited. Cognitive behavioral therapy, CBT, can help individuals confront and reframe their delusional beliefs, providing tools to differentiate between reality and distorted perceptions. Additionally, Support groups and family therapy may help in offering social support to patients and facilitating better understanding from loved ones. 3 cases mentioned before were mostly treated because they received professional help and treatments. It brings us to think how many people there are with psychological disorders and brain dysfunctions that they aren't aware of, and may just end up making life a misery for themselves and others.